It's my, it's my pleasure to welcome you all to this upper GI endoscopy session and hosted by G-Echo and the Gastro Foundation through the auspices of Project Echo. And I hope your weather elsewhere in the continent and elsewhere in the country is a bit better than it is here in Cape Town, where it's a bit damp and wet, to say the least. But nevertheless, that invigorates our speaker to come to the party and cheer us up with what is quite a commonplace emergency that we see um, over the spectrum of patients presenting in our environment, and that is those who ingest caustic substances and do their harm to the esophagus and the stomach and a few other organs as well. And it is to this topic that we asked Dr. Prof. Chinya to enlighten us again on this. She covered it about 18 months ago, and I'm sure there are slightly new perspectives on it, but having a good approach to this, which is ever changing as the imaging changes, is it's something that we should all be aware of. So over to you, Galya, and please, all of you, if you have some questions, post them in the chat.
All right, thank you so much. Thanks for joining us, everyone. Yeah, as Prof. Thompson said, this is a talk I gave actually recently, the first 20 slides or so regarding the acute management at SAGES. And then what I've added today is the additional management of the endoscopic strictures, and then just a brief rundown of what surgical options we offer, just for interest, obviously. So let's start off. For me, the first thing to look at was obviously when preparing this talk a while back was the literature, what's out there. And the World Society of Emergency Surgery has some guidelines on the acute management of caustics. Now, international guidelines are all good and well, but I do think we have to rein them in a little bit, or at least look at them more specifically as regards the South African context. And what I've done is I've taken a few statements from the guidelines and kind of adapted it to us, or at least disagree or agree with it. The first thing I definitely agree with is they say that the real incidence is unknown, probably underreported. That's a no-brainer. We'll all agree with that one. Then the second statement is that suicidal ingestion usually occurs in adults suffering psychiatric disease. We definitely disagree with that. Our local data is that we have a predominantly young male population, and only 15% are actually known with any prior psychiatric history. So that's not what we are seeing locally. Then take a look at these two videos. I hope they're playing. The first one is obviously of the laryngeal complex, going through beautifully, nice and clean, through into the cricopharyngeus and upper esophageal segment. Then on the other side, we now have the distal esophagus going through into the OG junction region, cross into the stomach and down towards the pylorus. Now, this is the same patient. And I've put this here for a very specific reason. The thing is, you cannot judge by the oropharyngeal burns what's actually lower down and how significant this is. So we are going to definitely agree with the second two statements that these guidelines are writing about. Clinical symptoms do not correlate reliably with the extent of GI damage. Agree. Absence of pain and oral lesions do not rule out serious GI injuries. Absolutely agree. And in our setup, patients with oropharyngeal burns, in 70% of those, they do not have any significant damage to the esophagus. And I think it is because the oropharyngeal burns are those patients that have some hesitation in their actions and keep that awful tasting acid in their mouth. and they may or may not swallow it. The actual true suicidal intent patient is somebody who gulps down the acid. And you actually, like in this patient, you see the majority of the injury more distal rather than in the oropharynx. Then a next statement, identification of the nature, form, quantity of the ingested agent, and whether it's accidental or intentional, are the cornerstones for emergency management. First of all, this is extremely unreliable or even unavailable locally, and we don't think the emphasis should be placed on this at all. So we're going to disagree with that statement. Just in theory, alkali ingestion obviously can lead to more serious injury and complications, but this distinction I think is probably not clinically relevant in the setting of a very strong acid or base ingestion. Both are able to penetrate tissues rapidly and potentially lead to full thickness damage of either the esophageal or gastric wall. And just for interest, it's actually, this is a murine esophagus where on the picture B, you're getting necrosis after 10 minutes of exposure to 10% of sodium hydroxide. If you increase the concentration to 30% sodium hydroxide, that full exposure, full contact, full thickness necrosis occurs in 1 second. So rather my thing is, it's not really what you're taking, it's the agent's concentration. And then of course the time of exposure that's relevant. Second thing that's very, very clinically relevant is the actual consistency of whatever was ingested, granules versus liquid. The granules are really pesky. They sit up in the top of the esophagus and they burn full thickness and give really bad upper esophageal strictures in the long run, if not penetration right through. The other thing about positioning is important, and this is just anecdotal from my side. I don't know if it's really true, but I do think there's some merit to what we see. If you're, whether you decide whether this is suicidal or accidental, I think it is important for the follow-up of that patient. And what you see here on the first two pictures is a retroflexion view of the gastric and fundal injury due to a caustic. And that's the kind of pooling you will get if somebody's curled up in a fetal position. Laterally, that makes sense. If they've taken it intentionally and they're feeling awful and they're lying in there somewhere in a dark room. Whereas the other picture on the right, you get a puddle of acid ingestion or caustic, whatever it is, in an accidental patient. They're walking around in the pub still. They get the pooling in the antral or gastric greater curvature region. So that distribution of injury is different, in my opinion, if you have taken accidental or intentional. Then the next statement, initial normal lab values do not rule out necrosis. Absolutely, we agree very much with that. And it is rather the trend of your blood results that are more useful. But how do we actually rule out a serious injury from the start? So that's where this acute management comes down to the nitty-gritty. The next statement is that plain radiographs may show the presence of free air and should be performed. We disagree completely with that. In our 100 patient series, not a single chest x-ray showed any features which either confirmed or did not confirm the presence of a perforation related to the esophagus caustic injury. And these chest x-ray did not influence in any way our acute management. So we don't think it's relevant at all. What about now, importantly, the grading of the injury severity? Clearly, that's the most important step. And those with full thickness injury must be identified and operated on early. So what imaging is actually nowadays recommended? Now, endoscopic classification of caustics, well, you'll all be very much aware of the Zaga classification. And I think just to remember here, there is relevance in it. Even now, it's 30 years old or even more, I think. Remember that each increase in injury grade correlates with a 9 times increase in morbidity and mortality. So it's really significant. When should you be scoping? That's the thing. So endoscopy is recommended in the first 12 to 48 hours after ingestion. Some don't recommend scoping after that due to the perforation risk. But I must be honest, I think if you are careful, you can definitely scope safely after 48 hours. And if a perforation occurs during your careful scope, trust me, it would have perforated anyway. So I don't hold fast to that 48-hour cutoff. I don't think that's a necessity. You can definitely scope after that as long as you're careful. Now, the major drawback of endoscopy is clearly its inability to accurately predict transmural necrosis and which patients should be offered surgery or where is it futile. So look at these three. These are different patients. Esophagus on the left, obviously, quite concerning. And my question to you is here, who would you operate? Where do you think there's full necrosis? So that's the first picture. The first patient. Here's the second one. You can quite clearly see there, hopefully as well, that the vasculature is thrombosed. So that one would concern me as well. And then finally, let's run that one at the same time. Nice pink esophagus. Coming down towards the OG junction, a little bit erythematous, a bit of blood. And then you come through into the actual stomach. Some mucosal necrosis perhaps, but I think you'll agree there's a fair amount of happy pink tissue around. So my question to you, who would you operate? I think we'll all agree without a doubt. Patient 1, patient 2, there's full thickness necrosis, that esophagus and potentially stomach needs to go in both. However, in patient 3, I think endoscopically, your esophagus is quite fine, and you'd be tempted to leave that stomach alone. However, that is actually the stomach of that final patient. So my point is just this: endoscopically, you cannot always accurately be sure of what you're dealing with. So your clinical reevaluation is essential. The new sort of kid on the block, not new really, but the CT-based algorithms are becoming more and more dominant and definitely are playing an important role. And the role is to select out patients for emergency surgery because you clearly have significantly improved patient outcomes when you do this. Whereas if you're only looking at your scope, like that last patient, you may well miss something there. The other important thing about CT classification is it can definitely prevent an unnecessary esophagectomy in some patients where you are grading it a grade 3B on endoscopy. So what do you actually look for? So grade 2, you grade them. Grade 1 is normal. Grade 2, a grade 2 injury on CT you can manage non-operatively. But these patients should definitely get a scope before they go home to predict what is their stricture risk, because the Zaga classification definitely predicts stricture risk well. Now, the CT-based algorithms to select patients for this emergency surgery do well. They are very good. What you have to define is obviously clearly, is there still some vascularity in the wall there? I hope you see my arrow. But look, there is quite a lot of soft tissue edema and increased wall enhancement. But the problem is number 3, grade 3, where you've clearly got an absence of wall enhancement. So there's no vascularity anymore there. That is a necrotic stomach. And the esophagus also, no enhancement anymore. And this is a patient that should go directly for an emergency operation. Now, what's better, CT or endoscopy? So ideally, if you can, you should be combining the two, especially as we said earlier in the cases of grade 3B. And that decision should then be easier to make if you add the CT. Now, the problem with that is how available is a CT in most of the hospitals where these things present. I think most of you will agree with us that endoscopic evaluation is available more easily after hours in most district hospitals in comparison to CT. So I think as regards the criteria for this, locally, we're going to stray off a little bit from this algorithm and say that endoscopy still performs well. However, what we're advocating for you to do is to please do an arterial blood gas, as any abnormality there, and that's a pH of less than 7.35, base excess of less than -2, or a lactate of more than 2 in our setup, significantly predicts full thickness necrosis. And those patients you should then send on for a CT scan. And this is something we've locally researched, and the outcomes are quite clear. I'm going to quite strongly say that EUS in the acute setting, zero value. Don't even consider for that. Obviously, the destruction of the muscle layers are observable at EUS, and that can then tell you, yes, there's going to be a stricture. It prolongs the examination time. There's no difference, and it shouldn't be even in your algorithm. So EUS, no. What about acute management? Is there anything you should do or not do? Gastric lavage or an induced emesis? Absolutely not. Don't do that. You're just simply going to re-expose the patient to the acid that he swallowed is now going to go back up the esophagus. So please don't do that. Neutralizing in some form whatever you think the patient's ingested, also not a good idea. Please don't. A nasogastric tube in the acute phase has no relevance, and again, it can also induce vomiting. A nasojejunal tube in the first couple of days, yes, if you are struggling with a patient that has got significant odynophagia or dysphagia. PPIs, I'm going to sit a little bit on the fence in that although they are recommended by some, I think the evidence is a little bit scanty, in that if you are dealing with a stomach with significant mucosal injury, you know, it's absolutely makes no difference giving PPIs in that scenario at all. So difficult in the acute setting, I would not give it routinely. However, if you have a long-term patient with majority esophageal injuries and you've got a fairly happy stomach and you're dealing with nasojejunal feeds that you have to leave a tube down for some time, that in itself, plus the kind of gastroparesis that you end up, and the irritation of the anti-reflux barrier will spontaneously have more gastroesophageal reflux. So in that case, over the long term, yes, perhaps PPIs. Steroids, no, absolutely not, unless you've got that very unfortunate patient where there's an addition of an inhalation injury. That's different. Routine broad spectrum antibiotics, no. Now, let's get to emergency surgery. The need to perform surgery, very serious implications, both on survival and unfortunately on functional outcome. And the biggest thing there is actually whether you need to resect the esophagus. And that is an independent negative predictor, obviously makes sense, of survival over the long term. But when in doubt, don't sit and wait. Actually go and explore your patient. Do a laparotomy. If it's negative, that's fine. We agree with that statement. Diagnostic laparoscopy is advocated by some. This is my opinion. I don't agree with that. And this is why. Here's a, oopsie, sorry. Oh, let me just go back. Apologies. So here's an open picture, obviously, of a laparotomy. Quite clearly, the stomach is absolutely gone. There's necrosis of the omentum. That's easy to make that call. You could make that call laparoscopically. The stomach's got to go. On the other end, here's a patient that we opened, had a nice looking stomach, and then something made us do a bit further of an exploration. We opened up the lesser curve and actually mobilized the ligament of Treitz, and this is the duodenum folded up. And what you see there is a clear imminent perforation due to necrosis of D3. Now that, trust me, is something you would not have seen at laparoscopy. So I think this is potentially one of those times where an open surgery negative might still be negative, so what? But that's a careful exploration you can only do with an open exploration, in my opinion. Okay, so I'm going to disagree with diagnostic laparoscopy. And then the final thing they mentioned is that these patients should be undergoing a delayed reconstruction. 100% agree with that. Only difference there is in our setup, we would be reconstructing them at approximately 3 months after their initial resection. And most European centers would be reconstructing at 6 months. Now, it's a bit different there. They can go home with their feeding gestures. In our scenario, we have to keep these patients as an inpatient. It's a big thing not being home for 3 to 6 months. It's also not feasible to feed them with a pump at home. So we have to keep them in hospital. And for that reason, it becomes a financial decision as well. And we opt for a earlier reconstruction than what is internationally recommended. We go at 3 months. Now, just a little bit of background as regards our cohort of 100 patients that Dr. Schreiber looked at recently. What we found was quite interesting. Full thickness necrosis is actually quite a dismal thing to get, and it's associated with a cumulative survival of only 17% at 2 years. And that's even if you've survived your initial surgery, did well, reconstructed, they just do poorly over the long term. It's a dreadful thing to do to yourself. So full thickness necrosis, absolute disaster, even if they survive. The other thing that we think is quite important to mention is that if there's full thickness necrosis, there's a 30-day mortality of almost 60%, and that includes obviously patients that we have selected out for palliation. Maybe I can just briefly tell you who we select out. So once there's injury beyond the sort of D1 area and it becomes a duodenal jejunal thing, that's a big problem, specifically if there's injury to the pancreatic side, the ampullary side, because to reconstruct that is quite a mission. We've done a duodenectomy with a reimplantation of the ampulla in a handful of patients. 2 of them went well, the others did not. So that to us is very much pushing at the edges of reconstructive surgery there. If you open up and there's clearly already injury to the pancreas or the colon, it's a done and dusted deal. We would close up and palliate that patient. Patients that require an acute resection, and that's now without those that we've palliated, have a 30-day mortality of 36%. So it's high. And in the worst case scenario, if you get a patient that's already perforated at surgery, 90% will die. So it's a disaster. So you really do need to catch them before they perforate. Let's talk a little bit about stricture prevention in the acute phase. Does anything really work? So systemic steroids, no. Intralesional triamcinolone injections, tricky to answer that. The optimal dose, how often and when to actually give it, is not quite clear. And it's really, the research there is actually obviously more in the chronic setting. So it's definitely not something I would do in the acute setting. It's also not available locally. Do antibiotics make a difference? No, they don't. Nasogastric tube, there's some people that say it is beneficial in that it keeps some patency of your lumen. And then there's the other side of the spectrum where people are saying, no, it's not a good idea because the nasogastric tube increases your potential for reflux. And so you get a second hit against your esophagus. Yeah, I'm in a bit of two minds there. I do think it's easier to dilate someone who's got a bit of a lumen there. And we definitely are firm believers of long-term nasojejunal tube feeding if necessary. and we have not found much of a difference as regards stricture rates when we do that. So I would put in a nasojejunal feeding tube if necessary. Mitomycin C, no real evidence in the acute setting, not something we would consider. There's a little bit of benefit in pediatrics, but in the chronic stricture setting, there isn't much as regarding the adult population. Stenting, not in the acute setting. And the reason for that is that radial tension of your stent will further decrease the vascularity of what little is left there. So not in the acute setting, absolutely not. For a chronic stricture, we'll discuss that later. I do think there's a place. So to just wrap up the acute adult caustic approach, let's just a couple of things there. Firstly, very important, identify full thickness necrosis, because you can only save someone if you resect them early before they perforate. CT, most accurate for sure, looking at the enhancement of the wall, very helpful, but we accept it's not readily available. So for us locally, endoscopy remains an important and invaluable tool. And I definitely think you can do a scope after 48 hours if you're careful and experienced. We propose to you, though, that you should add an arterial blood gas to select outpatients that you need to acutely refer to an academic center for an emergency CT and subsequent assessment for surgical resection. And then obviously delayed reconstruction is the way to go. So let's go to the second part and look at the caustic strictures. What do we do there? Now, I think most units, high volume units, will deal with a lot of caustic strictures, and they can be jolly frustrating. Patients are tricky, the strictures are even trickier. And I think it's a long-term inventive management that you have to kind of think out. The proximal esophageal radiation strictures are also equally difficult. Let's not talk about them today. But I just put up here the difference as to chronic strictures, the two most common ones. The peptic ones always seem to have this superficial slough around it, which is when you brush it off with your dilatation or your scope, very bleedy and unhappy underneath. It's generally quite a soft stricture, whereas looking at the picture on the right, that slough is completely absent, and you can just see that fibrotic tissue in the background of that mucosa. You know that's going to be a caustic stricture. Your considerations should always be pre-dilatation, the length of your stricture that you think you're dealing with. What is your residual lumen diameter? So what are you actually starting with? And where is it? Very important. Where is it? So everybody always asks, what do I think is best, bougie or balloon? I don't think either is best. I don't have a personal preference. I think a stricture has a specific preference. And there are times when you may start off with a balloon and then you swap over to a bougie. Both have a role. I think you should have both in your endoscopy suite. Remember that a bougie has the benefit of a biaxial force, longitudinal and radial. And the big advantage there is if you get your bougie down, whatever, 10 millimeter bougie, you know that your stricture was dilated to 10 millimeters. That is not guaranteed with a balloon. And in this day and age, it's obviously the cheaper option, fantastically reusable for years and years and years. And the other thing I think which is beneficial here, you can actually, as you push the bougie down, you can feel how much resistance there is and get an appreciation back, tactile, of how tight is that stricture. On the other hand, what about balloons? What they can do is they can get through tighter strictures, where you've got strictures that are just a few millimeters, they can get through that. But you're not guaranteed to reach the diameter, even if you pump it up to the atmospheres as mentioned on the manufacturer's specifications. Other benefit is you don't need to take your scope out. You can actually watch your stricture dilating, which is quite nice. And remember that they only have radial force. So there's pros and cons to both. just to show you quickly how I would like you to do a bougie dilatation if you are using a metal wire. I think it's quite important that look, ideally you need fluoroscopy, specifically for the tricky ones. I do think it's safer with a bougie to use a metal wire because you've got that stiffness. If you're not very familiar with the soft jag wires, you can, when you push a firm bougie over a soft wire, perforate at the cricopharyngeal region. So that's not such a good idea. But this is how your wire should lie, beautifully straight, and the soft flexible point that can bend, but you need a straight wire. What you do not want is that your wire makes this kind of S shape, because once you push a bougie down with that shape, you get two additional points of high pressure. The one is at the OG junction, and the other is up at the cricopharyngeus. And you can actually perforate those two areas, not your stricture. And I say that because I've done it. I know that happens. So keep your wire nice and straight. Don't get this S shape as you push anything down a metal wire. Here's just a quick video. There you can see the radiolucent marker coming down, crossing the OG junction, and at the whole duration of that scope, you pulling back on that guide wire such that that stays a nice smooth movement, and you don't get that bowing of that wire. Now, the rule of 3 versus rule of 6 as regards bouginage. It was initially adopted, the rule of 3, in an effort to decrease the perforation rate. Now, the first dilator that causes you any resistance to passage counts as number 1. And then after that, only 2 additional increases in sequential size are passed per session. Now, this is not evidence-based, and it's limited, of course, to bougie dilatation. The other option is that you continue until you feel firm resistance, or when you come back, there's a bit of blood at the tip of the dilator, which is more than just a slight bit of blood. The other option is you go with a rule of 6, where there are 3 consecutive bougie dilatations performed in increments of 2 millimeters each. And neither of the two have an improved, a decreased perforation rate. So I think both are safe. And it becomes really a kind of a tactile thing. And what diameter you start at is obviously very important when you're looking at what's left of your diameter. Balloon dilators generally inflated with water or contrast or a mixture thereof. And then you go up to the pressure that the manufacturers have specified, and constant radial pressure forces are applied to that stricture. Don't be tempted to buy the cheaper balloons where you don't have the radio opaque markers. It's really quite important to know where your balloon sits before you blow it up. They do come with their own guide wires. I don't like the guide wires. They're quite stiff. They got really bad memory. So I usually pull the guide wire out and put a standard jag wire through. I think they're much more forgiving and much more user-friendly. Yeah, I also think the balloon wires are just too stiff and short for any form of complex stricture dilatation. So ideally, your balloon should sit with a stricture located quite centrally. And once the balloon wastage disappears, that's kind of when your stricture is dilated, and then you shouldn't really proceed after that. And it's my opinion, with tight or complex strictures, I stop inflating at that point, rather than increasing to the specified pressure. Now here you can see quite clearly a very short stricture. That's the jag wire going down, the balloon, and it's nice. You can actually visualize, and you can place yourself in the middle of that balloon if you don't have fluoroscopy. And on the fluoroscopic image, you can see the insufflation is a little bit off center. It's actually a bit too high. We should have pulled that balloon back. But as you inflate, you can see the waste disappearing until it is a nice smooth balloon, and hopefully you've achieved the diameter. You can see this patient coughing and heaving. Sorry for the rubbish video, but this is how it is. I think when you're dilating, it makes a lot of sense to have really good sedation on board. Because if you're coughing and heaving against a balloon dilator or even a bougie, you can tear that stricture of yours. So yeah, be careful if you don't have good sedation. The other advantage of a balloon, get up nice and close and personal, pop your screen onto the balloon, and then what you can see is this beautiful fibrotic band, and you can watch it as you dilate. And if you start seeing red, you know that you're going a little bit beyond what you should be, and you're starting to tear that fibrosis. So that's the nice thing about a balloon. You can actually watch what you're doing. Here are 3 mucosal tears that I've made over the last couple of weeks or months, I can't remember. And my question to you is, which of these images concerns you most? Here you've got a single tear, a little bit of blood. I've got 2 tears here. Looks like the mucosa is still intact. Yeah, I can't really see much. So clearly, this is obviously a concerning one. The more blood you have, the more you should worry. Don't just ignore this. If you don't do a check scope, number one, you're being negligent. And if you see blood like this, number two, if you don't put down contrast and check that you don't have a leak, I think you can be in trouble. So this is a patient I clearly perforated. What you can see is quite clearly intraperitoneal air under the diaphragm, yeah, all over the liver. And what I've done here is actually, unfortunately, perforate the OG junction. Now, interestingly, if you find that really quickly and you put down a stent immediately, there's no contamination. And our routine practice is then to admit for antibiotics for 24 hours. We then confirm a swallow the next day to confirm that everything is sealed before the patient starts taking in orally. And then we discharge that patient and we remove that stent within 2 to 4 weeks' time. So if you catch it at the time of perforation, there's very little long-term complications. It's the one that you've missed and comes back 2 days later with peritonitis or mediastinitis. That's obviously a problem. Now, any advice regarding insufflation size with a balloon dilator? I think that's important. Personally, I'm guided by the residual lumen that's there and the length and, of course, the etiology. And I'm very wary of caustic specifically, and more so if this is the first time I'm doing that specific patient. I think we can all be in agreement that anastomotic strictures, on the other hand of things, are quite forgiving, and you can go right from the start up to an 18-20 millimeter balloon. But in the caustics, be careful. I would probably in the initial period never go more than 12 millimeters. So go slowly with the caustics, get to learn how that esophagus reacts to your dilatations. What about insufflation time? Now, randomized trials have compared the duration of balloon dilatation for benign strictures, and the results kind of show equal efficacy with no difference, significant difference, between the 10-second and the 2-minute groups. Remember that dilatation is quite painful, so the shorter time period is more preferable, but you obviously want something that's quite effective. So there's no benefit waiting for more than 3 minutes. So it is our practice to go for 30 seconds, sometimes 45 seconds. We don't generally go all the way to a minute unless it's a pyloric dilatation. That's different. But in the chest, we stick to 30 seconds. Now, what do you do in the dilatation or the patient where you are dilating every 2 weeks and you just end up with this residual high dominant stricture and you're not winning at all? What are some options? So firstly, I think you do need to know which bracket, which group your patient falls into. So most strictures with time will have a good outcome. However, remember that 40% of patients will require more than 3 dilatations for benign strictures. If it's a caustic stricture, goodness me, that number shoots exponentially. So caustics are the tricky ones. Refractory stricture, just the definition, it is the inability to successfully achieve a diameter of 14 millimeters over 5 sessions done at 2 weekly intervals. Okay, that's refractory. Recurrent strictures, that's where you are unable to maintain an adequate lumen after 4 weeks once you actually did achieve your target of 14 millimeters. So the two are different. I think you'll agree that most caustics will fall into the refractory group. Now, what are other causes for refractory or recurrent esophageal strictures? And I think it's something to consider, in that your patient doesn't necessarily just have the one etiology. So these are some common things that might be the reason why your stricture is not resolving with your dilatations. And unfortunately, we often forget that pull esophagitis can be a very nasty thing. If you've got a stricture and you get pull esophagitis above it, you're perpetually just giving that inflammatory response, stricturing happening there. So that's something to consider. If you have a stricture, tell your patient to open up your chronic tablets and swallow them as a liquid rather than a tablet. Don't forget EOE. And then peptic strictures are your patients taking their meds properly. And of course, there's very little you can do once you've got an established caustic. So what other options do we have available if we have a refractory or recalcitrant stricture? What about intralesional steroids? I mentioned it to you earlier. In the acute setting, no. However, in pediatrics, if you inject triamcinolone acetate into 4 quadrants, the results are encouraging. Now, that's when you start using words like that in articles, it's not really evidence-based, it's encouraging. Problem is, we don't even have that in the country. We've tried using DEXA, 2 milligrams into each quadrant. And anecdotally, between you and I don't think it's making much difference. So we don't really do it as a routine. We're really only when you're desperate. Mitomycin C, you've got the option of topical versus injecting. And most reports are in topical application in pediatric caustics. There's 1 or 2 articles in adults, but again, very vague potential benefit. There's nothing significant reported. Now, this is something I do think works, and that is incisional therapy. And the idea here is that you actually split the fibrotic band at various spots. You basically cut it away and to prevent it from reforming. So if you can almost think of it like marsupialization of an abscess, and then you take your instrument and you take off the little bits of tissue that you've divided. I use a needle knife. It's the cheapest by far, the same needle knife that you do your ERCP with. To use a nano knife or a TT knife and all those beautiful instruments, that becomes ridiculously expensive. So do use, if you do it, a needle knife. Remember that your needle knife comes out almost a centimeter. So just be careful with the tip that you aren't seeing on the other side. Here is a perfect stricture, caustic stricture, short, tight little fibrotic band, and you know that you're going to do something good there. The tricky ones are, of course, the long strictures. But if you've got a short stricture, and that usually occurs in the cricopharyngeal region, where you get some stasis of your ingested caustic, you get this tiny, tiny lumen with a very tight, short stricture, perfect for a needle knife. This is one of the first ones I've done, so it's a very hesitant, careful one. You can see I'm nibbling. I'm not going really very far. But the end is that you end up with this beautiful splayed open caustic fibrotic stricture there. So the other option in these longer strictures, where you can obviously see that that's not going to work with incisional therapy, there we've tried stents. You should always remember to use a fully covered stent, in that it's not a permanent thing. You want that thing out at some point. The side effect is obviously the lower down they are, the more you get potential for reflux, and you can convert someone who's just got a stricture from caustic ingestion to someone who's got a caustic ingestion plus a peptic stricture above the stent. So yeah, it's not a decision to make easily. Take some caution in making that decision, but you do have a situation every now and then where you have to. Self-expanding plastic stents, we don't have them. We don't have biodegradable stents. The biodegradable ones also are reported to give a lot of hyperplastic reaction. So in a stricture, I think that's silly. So we use the bog standard, fully covered self-expandable metal stents. Now, this is a algorithm for refractory stents. What do you keep doing? So we're now at the temporary stent placement. And the next thing that we cannot do, but by all accounts works really well, is self-dilatation, where you give the patient a bougie to take home and they dilate themselves every single day. This works well. There's a lot of reports where refractory strictures have done well. Now, the problem with that is, and I'm sure most of you will have the same issue, we've got one set of dilators. You can't send your dilators home with people. It's just not feasible. You'll never get them back. So your final option is then obviously surgery. Let's quickly talk about reconstruction. As I said, most people will advocate a 6-month reconstruction period. We aim for 3 months. And how you reconstruct, obviously very much individualized and depends on what damage is specifically present in your patient. The fancy word for fibrotic stricturing due to caustics is cicatrization. And what you see here is a patient with nice, beautiful antral cicatrization and a pyloric channel stricture with a near complete goo. What's your option there? Well, quite clearly, partial gastrectomy or gastroged, potentially if there's some nice soft stomach above that, or on the odd occasion, you might end up doing a total. Depends where your stricture is. Now, once you've removed your esophagus previously, what do? Ideally, the best conduit once an esophagus has been removed is the stomach. If you've still got that, fantastic. By all means, use your stomach. And what you see here is, I just wanted to show those of you that don't deal with esophagectomies too often how we do it. We're up here in the neck and we're dividing through the healthy esophagus. And here we are making a gastric tube. And that gastric tube, you basically converting a nice fat, chubby, kidney bean shaped stomach into a long, skinny tube, which should be able to reach up all the way into your neck as needs be. So there's your nice tube that you've created. And the big thing there is, I hope that is clear. You've got your gastroepiploic vessel there, and the quality of that is essential. That's a beautiful one, beating away there. And as you see here, it can reach right up into the pharynx if you need to. The way we get it up, we put a pencil drain down, and then we attach the stomach tube to the end of the pencil drain and then pull it back up through the chest. If it's a delayed reconstruction, we actually prefer to do a retrosternal pull-up, in that you then avoid going back into the chest. Big thing is obviously to exclude an anastomotic leak, and you can see here there's day 6 or 7 swallow being performed. Here's your gastric tube. There's the air fluid level, and you can see it's quite a distended tube. And that is, remember, that you've actually divided your vagal nerves, and your stomach takes some time in getting used to emptying by itself again. And there's always an element forever and ever of delayed gastric emptying. So these patients are, as a routine, advised to have small, frequent meals and be treated as reflux patients. If you've taken out, on the other hand, your esophagus and your stomach previously, well, then what are you left with? You're left with a colonic interposition. What segment you use is very much dependent on the vascularity when you get there. You can do a CT angio of the colon beforehand, doesn't really help you. You have to see what you're able to get on the day when you actually operate. ideally isoperistaltic. So you can use the terminal ileum going all the way up to the neck. Do take your appendix off, of course, and leave yourself a tiny stump of terminal ileum. That diameter goes nicely with the diameter of the residual esophagus, much easier to attach than going directly onto the cecum. And as I mentioned earlier, we like to avoid the chest opening up in the recon a couple of months later. We go in that beautiful retrosternal space. Here's somebody who had a really bad laryngeal stricturing injury requiring a long-term tracheostomy, and we converted that into a permanent trachea. And what you see here is the colon being attached directly onto the pharynx. So we've done a laryngectomy. There's the salivary glands, and the colon is being anastomosed directly onto the pharynx. Your best friend after this surgery is your speech therapist, in that these patients require basically relearning how to swallow, and there are some tricks and tips that the speech therapists have up their sleeves, and very useful to make friends with your speech therapist. It's really a multidisciplinary team that has to work with these patients. For your dietitian, once you've done a colonic interposition, they are always super keen to carry on with the enteral feeds. We routinely give a week of post-op TPN, and it's quite clearly why. I've got 1, 2, 3, 4 anastomoses. I've mobilized the entire small bowel colon. You have definitely got a patient with a long ileus post-op. So we give routinely TPN, and we start using our feeding jedge only once the ileus has settled. Just for interest's sake, this is one of my favorite videos. I'm sorry for the quality of it. It's on my phone. But what you see here is us scoping a patient that we've done a colonic interposition on some years later. And you can quite clearly see its colon. But isn't it cool? You've moved your colon, makes sense, but it hasn't forgotten that it's a colon. And here it's making almost little stool balls out of the food that the patient has eaten. So it still maintains its function of primarily being responsible for water absorption, and it's making little poo balls out of your food. And this is now in your esophagus. Well, so that's quite cool, but for the patient, not so nice, in that the colon is very redundant within a couple of weeks. This is a swallow done after 6 weeks, and I can assure you, trust me, we pulled this thing up straight. There wasn't any redundancy, but within a couple of weeks, and definitely by a few months, you've got this twisty, tortuous colon. It's sluggish. It's difficult to get that food down, and you will see these patients come back, if they survive, after years with massively dilated colons in the chest. Real problem to sort out. Now, the problem that you sometimes get, and we're almost done, is that the surgical reconstruction options at the proximal end is obviously where your anastomosis is at its highest risk, and you can get necrotic breakdown there during your reconstruction. So how can you fix that? You can put short interpositions in with a radial forearm free flap. That's one option. You can see it here. We make a little tube out of a piece of skin, and it's got microvascular requirements from your plastic surgeon. We take it from the forearm. Yeah, it's quite a bulky thing. And what you see here is actually going through that interposition. It's quite weird seeing a hairy esophagus. But in the couple that we've done, we've probably done about 10 now, they generally don't do well, in that you cannot get skin and GIT mucosa to heal together very nicely. So there you're going through into the colon. They invariably leak and have fistulae. So it's quite an unsatisfying thing to do. The other option, again, using skin, is a pectoral flap. The advantage rotation flap is that you don't need a microvascularization there. There's your tube that you make, again, bulky, and you've got the jolly skin trying to attach. What's better is probably a jejunal interposition. That's got the best functional outcome, and definitely we've had some good results there. You need to pick yourself a nice, beautiful segment with a lovely arcade. Choose that segment. You need your plastic surgeon there from the start. They need to determine the diameter of that arcade is good enough, with a feeding vessel being attached to either the inferior thyroid directly onto the carotid, or we've done it on occasion onto the internal mammary. And you can see that little piece of jejunum quite happily mobilizing there. And there it is once it's been attached to the residual colon and up in the neck. So to finish off, I think in the acute setting, gastroscopy has a role for sure. In our setting, blood gas, arterial blood gas must be done. I think helps you decide whether you should refer as an emergency for a CT. When in doubt, explore surgically. Once they perforate, remember, almost 100% mortality. So rather get a negative lap. And as I said, I prefer an open surgery there. Delayed reconstruction, absolutely essential. So make sure that you have good long-term enteral feeding access. This is not something for TPN. So put in the feeding change at that initial operation. Chronic strictures, be super patient, persist with them. Try alternative techniques before you go and tell this patient they need a resection. Delayed reconstruction, remember, if they do survive, they've got major quality of life impacts going forward. And I cannot tell you how important the long-term psychosocial support is. So these are patients that will be with you for many, many years if they survive. And they're never quite happy. It's a devastating thing to do. I think I'm done and a little bit over time. Thank you so much.
Hi, Galya. Thanks very much indeed. That was really absolutely superb, and particularly right at the start, as the approach to the whole problem. I don't see any queries in the box. I do remember in my former days, I used to deal with these patients quite a few years ago back in Durban, and we had one patient that we actually wrote about. I almost identical to the patient that you had here, who presented with esophageal necrosis, and we called the thing in total esophageal reconstruction, try and try again. And this poor chap ended up having a stricture in the neck, which was the main limiting factor after he had a colonic interposition. And his jejunal graft failed. And then, so we did it in the reverse order, because it was felt that the jejunal graft would be the better than a forearm flap. But he ended up having both. And
Yeah.
the problem that they had there was the feeding artery that was feeding the jejunal flap. And they got that wrong, and that resulted in necrosis at about 2 days. So I think these things are highly technical for them to be successful. And this poor chap was in hospital for a total of 18 months. So I think it illustrates exactly what you say about social circumstances of the individuals who are coming to the state hospitals with these problems. They just really are not manageable in any outpatient way. But can I ask you another question? You're very fond of nasojejunal feeding, but
Yes, I am.
when do you feel that one should go to a jejunostomy? Is that an option if you explore the patient and they do have one of these necrotic situations which is resectable? Would you then place a jejunostomy, or would you try and do something else?
So in the scenario where you've got significant odynophagia or even dysphagia, from the word go, when they arrive, we put down a nasojejunal tube at that first scope. We put it down from the start. The inflammation can be so severe, as you know, Prof, that it takes them a week to 2 weeks before they even get any liquids down. So I think the healing process is definitely aided by having good nutrition on board. So we put it down at the first setting. If I'm doing a laparotomy, on the other hand, and it's a negative lap, and I think I'm going to get away with things, do I put a feeding gedge then? Yes, I do. You can pull out a feeding gedge, but you at least have that backup plan for nutrition once your stricturing starts, and they will stricture. These esophaguses are awful. And then the pyloric strictures are not uncommon either. So we don't rush in once we've got a confirmed stricture. We fatten them up, and we'll do it once the dietitian is happy. There's no rush as long as you've got adequate access from the start. So yeah, I'm quite aggressive with putting enteral nutrition routes in.
And of your series, how many of them are just the esophagus, and how many of them are the esophagus and the stomach, or vice versa?
So the majority have a component to both. What we find is that the intentional suicides have from the start significant injury visible on the scope in the stomach, because there's such an amount there. They often have no oropharyngeal injury at all. And then because it's such a, they almost gulp the stuff down. I'm just imagining, I obviously haven't seen it happen, but they seem to gulp the stuff down, and the majority of the injury is then distal esophagus and stomach. The sort of tentative, we've got one kid that tried to irritate her mother and took drain cleaner, just a mouthful. She's been with us for 3 years with the most horrendous mid-esophageal stricture. So it's not always how much you take, but she took granules. And this is a problem. It's going to be a problem for the rest of her life. What a stupid thing to do. So I can't, yeah, I think the real suicides have a gastric and more distal injury, whereas the tentative sort of accidental or kind of just irritating my mother ingestions is more proximal. We've also had horrific 5 or 6 patients where it was an assault with a forced caustic ingestion. That's that's something else. That's a lot of oropharyngeal injury because you're not wanting to swallow. And those are the patients that come with an inhalation injury. Horrific. It's just, you can't believe people do that to each other. And we had one lady that we got through on ECMO, that David got through on ECMO. So yeah, I think it depends on the intent of the patient, where the injury is. I don't know if that
Reed, I
helps.
see your hand up there. Would you like to ask a question?
Yeah, thanks, Galya. This is maybe sci-fi, but I know you all guys remember somebody from the American Endoscopy Society came to SAGES a couple of years ago, and he was talking about stem cell transplants in these horrendous injuries of the esophagus and abnormalities. Is there any new data on that? And that maybe not the way to go?
Not that I'm aware of, no. I also think it's sci-fi, but out
You,
of
you,
our
you
reach.
think you think his presentations were sci-fi? We better tell Chris that.
Uh,
Uh,
mm, I'm going
Sandy?
to remember that with some caution and yeah, some
yeah.
skepticism, perhaps, so that's
His,
might not be for our patients, no.
his name is Dr. Kowinda,
Yeah.
and he is a bit of an esophageal expert. But interestingly enough, you might remember a gentleman, Galya, maybe a bit before your time, but unfortunately he passed away recently. His name was Cedric Bremner. He was the professor in Wits, and
Edwards,
he
yeah.
was Dr. Esophagus. Yeah, he passed away. He stayed in a retirement village in Hawick. He retired back from America. He went and worked with De Meester for 8 years when he turned 65, and Wits gave him the sack. He's an interesting chap. But this chap, Kawinda, I think has done some novel work on it. But I think the sort of technology to do these grafts on skeletons. So they put the graft on, they put the stem cells on the actual delivery device,
esophagus. Yeah.
stent, yeah, which is a stent to hold it in place.
Yeah.
And again, goodness knows how effective it is and how practical it is for us. I think it remains a research tool in very isolated circumstances who've got all the bells and whistles that you can imagine. And I'm not entirely sure if it works.
But Sandy, sorry, I mean, I'm raising it because this is obviously a horrendous disease, and no matter what we do, we're going to get into trouble, and all of us have seen it. I'm telling you this because a neurologist here at Wits is growing stem cells for the spinal cord. So I think we shouldn't, and maybe one of the young surgeons should take this up, like the HPB said. And stem cell transplantation there might be a place for it. I know we're growing spinal cells in people who have been paralyzed and sectioned. The rats start walking again. So it might be sci-fi, but it might have some hope for us. Anyway, that's my little penny. Thanks, Galya.
Thank you.
Yes. I think one of the most interesting things about that stem cell thing is that it was originally used when they, to my knowledge, when they used it on the trachea, because the trachea, to some extent, is just a scaffold, and so they've used that technique of implantation of stem cells in the bronchus with some success, but I think also with some problematic cases in Sweden that Professor Jonas, I think, it caused quite a bit of for academic fraud at the Karolinska Institute when this chap was replacing these organs with a matrix with stem cells. So I think you really have to know what you're doing if you're dabbling with that technology, and your institution has to have the whole wherewithal to manage it. So yeah, I think sci-fi or advanced medicine, I think for the majority of our patients we have is not going to be an option for sure. I had one other question, Galya. Of your 100, how many are truly accidental and how many are para-suicide attempts? I'm just interested to know that.
It depends very much on the patient whether they admit to it or not. Our younger male population is very reluctant to admit an intentional suicide, and I think the endoscopy often gives it away. So if you find a lot of, you have to drink a lot to get such a injury. It's not an accidental thing. That stuff reeks. It tastes awful. No, so I don't buy the majority of our young population, our young men. I don't buy it that it's accidental. Really, I don't. And if it's this fundal pooling where you can just see them lying all curled up, that was intentional. Sorry, I don't buy it any other way.
Yeah. Sure. No, I think, again, I used to remember we did a lot of scopes for so-called ingestions, where really the endoscopy, and it's another reason to use endoscopy liberally, is to exclude that there's significant injury. I don't think one should undervalue it as a tool to do that. And and again, obviously, if they have any systemic illness and they look systemically ill, that's obviously when you have to press the bells on assessing them really fully in terms of a CT and support organ support investigations. So I think really that was excellent, and yeah, I loved your bit on the practical tips of how to dilate these strictures. I think they're unbelievably worthwhile, and certainly my message there would be that if you're tackling these strictures, you must have fluoroscopy, unless you're very expert at them and they're very short and single. Everything else, I think, is risky for the patient, even if it's not the first time you dilate them. So for me, I think that's the use of fluoroscopy, so you can have the whole system controlled and you know if you've perforated there and then, is a great asset. And so I wouldn't think that the amateurs should be dilating these these strictures. So thanks again, Galya, for that.
Yep.
So there's Sydney here said, what's the best time to scope? I think the best time to, do you want to answer that one? The best time to scope if they come to you early, as soon as possible.
Yeah, as soon as possible. And as I said to you earlier, I don't believe the cutoff of 48 hours. I think you can do a careful scope after that. So the sooner the better. Yeah.
One other question here. What's the best time to dilate? So once you've assessed the injury, you've passed your nasojejunal tube, when would you reassess and consider
Yeah.
dilating?
So I wouldn't consider dilating before sort of 3 weeks, and that's just my opinion. Maybe there's somebody else who's got a difference. I think in the initial period, there's a lot of inflammation, edema, all of those things, potentially compromised vascularity. Leave it alone. Just let the whole thing settle. If it's a very high grade stricture, then we would start gently putting a balloon down, sort of, and you're not going to go more than 10 millimeters. Very small, gentle dilatation, under vision. That's when I do under vision, not a bougie. And then you take it from there. Otherwise, if they look reasonable, they're managing a soft diet, we send them home with a planned rescheduled scope under fluoroscopy in 2 weeks after their discharge. And we just see what's left.
Thank you very much. On that note, just remains for me to thank Galya for updating us, and also her own data, which it's good to see that you've collected that, and it gives some valuable insight for how to manage it in our setting. So thanks again, and thanks to everyone here. This is recorded, so you can access it through the Gastro Foundation website, and it's just up to me to thank the iEcho staff in India and the parent New Mexico group for hosting us on the iEcho platform. And we look forward to seeing you next week for the pediatric one, and in the future for further endoscopy ones. So thanks to everyone. Goodbye for just now.
Thank you. Goodbye.
All right.